Hello guys, and welcome back to a brand new episode of the BFAM Weekly Podcast. I'm your host, Dr. Hassan.
Dr. Miriam Wamboi here.
And Dr. Vata here.
We are pharmacists, and one of the major issues we deal with at the pharmacy setup, I feel like it's gastric issues, right?
Yeah.
What do you think are the major issues that we deal with?
Okay, the chief complaints that I normally see, especially in the community setup, is peptic ulcers.
And also diarrhea, or Dr. I have a runny stomach or nausea and vomiting. I think that's also a very common one, especially with the kids.
Yeah.
So, how are we able to diagnose based on the chief presenting symptom from the patient?
So maybe we can start with the peptic ulcers. The patient will come to you complaining of heartburn.
Yeah.
Or a burning sensation, epigastric pain, somewhere upper between in layman's language, between the chest and the stomach.
Yeah.
They'll experience a burning sensation, and then the acid reflux. I think that's the major chief complaint they come to you with. And then there'll be maybe a history of, Dr. I've ingested this and this, something acidic, maybe carbonated sodas, or they've had the issue for a period of time. Then from their history, you can either deduce, you can suspect maybe something like H. pylori or just normal hyperacidity, depending.
So sometimes when you talk about stomach ulcer, there's usually that thin line between stomach ulcer and GERD. Dr. Can you please elaborate what is the differences between the two of them in terms of how they manifest and all that?
I think the major difference between GERD, which is gastroesophageal reflux disease, and peptic ulcers is the reflux part.
Yeah.
For GERD, there's normally loosening of the lower sphincter of the esophagus, which allows acid to come up the esophagus. So you'll have burning sensation towards the esophagus. And there's also going to be some sort of pain, hoarseness of voice, coughing, and all that. So it will be majorly towards the upper part of the GI.
Yeah.
While the peptic ulcers will just be feeling the epigastric pain.
When you look at the physiology of GERD, gastroesophageal reflux disease manifestation, do you think which one causes which? Do peptic ulcer cause GERD, or does GERD cause peptic ulcer?
I think it starts from the gastric part of it. So you might be having hyperacidity, which is uncontrollable. It ends up weakening the lower esophageal sphincter. When it loosens up, some of the acid will be going upwards.
Yeah.
Okay. And also
so you'll have some reflux.
Also, if the person has other risk factors like smoking, which can loosen the esophageal sphincter, also the acid now will get into esophagus, which that will be GERD. Or maybe alcoholism may also predispose one to having GERD.
There are some, I don't know what I will call them. I'm a habits that the public usually have that predisposes them to GERD. I don't know whether they are true or not. For example, I've heard that when you take food to bedtime, it cause issues with acidity. Or also, there's a way that you're supposed to structure your bed. That's why we have pillows to prevent that. Is it true? How is that related?
I get you. Maybe there's some people who say lie on your right or lie on your left to ease. I think those are ways of easing the symptoms of GERD to prevent the reflux issue. After you don't lie down immediately after you've eaten, gives your body some time to digest the food that you've had. I think those are ways to sort of mediate the symptoms that people experience.
So now let's delve into the management of the two, both GERD and peptic ulcer, and the differences in the way we manage them.
Okay. So first, for the peptic ulcers, when we were mentioning the causes, I think one of the major causes of peptic ulcer disease is the H. pylori. So depending on the duration of your symptoms, for how long you've had the symptoms, we can suspect H. pylori, where you will have now to go into the hospital for testing.
Yeah.
To because we don't treat H. pylori empirically, we have to, it's a targeted therapy. So if you diagnose positive for H. pylori, we'll start the treatment regimen for that. That will arrest the disease at the root cause. I think that's one way of management.
I think also before even reaching to medications, there are patients who are on chronic NSAID use.
Yeah.
So you might find that the root cause of the peptic ulcers is actually NSAID use.
Yeah.
So it's important to take an elaborate patient history to figure out if the patient is on NSAIDs.
True.
So if they are on NSAIDs, you recommend those COX-2 inhibitors, which don't affect stomach acid. So apart from that, there are also lifestyle modifications that the patient can do, especially like avoiding spicy foods, fatty meals.
Yeah.
Alcohol,
Quit.
coffee.
If it's quitting smoking,
Yeah.
because it's also a risk factor for that. Yeah.
So I think from what I'm getting, you can't really treat peptic ulcers effectively without
knowing the
targeting the root cause.
Yeah.
Yeah.
We must first try to establish what the root cause is, so that we can treat it. Otherwise, we'll be treating the symptoms, but the underlying issue is still there.
Yeah. And also before going towards the H. pylori kits, we must figure out first, we must do the definitive test to figure out if it's H. pylori which is causing the peptic ulcers or it's just hyperacidity. So if it's just hyperacidity, we normally manage them using the PPIs, the antacids. You can combine them in different ways in order to relieve the patient of the pain and also reduce the acidity. So if it's a test that has been done and it's established that H. pylori is the major cause of the stomach acid, we now go to the H. pylori kits.
Yeah.
So I think for someone who's listening and they don't know what H. pylori is, maybe we can elaborate to them, and also the names that you're throwing, COX-2, PPIs.
Yeah.
I'm sure there's someone who's listening and they don't know what you're speaking about. So maybe we can start with the H. pylori. What exactly is H. pylori?
Okay, H. pylori is a normal flora. It's a bacteria that is found
In the gut.
So it's normally there,
Dormant.
part of the GI system. It's dormant. But when someone has acidity, there's usually corrosion of the gastric mucosa. So when the gastric mucosa has that corrosion, there's infestation of the gut lining by the H. pylori.
Yeah.
So they colonize that area, they dig into the tissue, they start producing ulcers. So that ulceration combined with the acidity of the stomach intensifies that ulcer, and the patient now starts
experiencing the
complaining of epigastric pain and all that, bloody stool.
Yeah, vomiting blood.
NSAIDs are nonsteroidal anti-inflammatory drugs, which are usually given to patients who are experiencing pain and inflammation. So there are usually two categories. There's two enzymes that are majorly targeted by these nonsteroidal anti-inflammatory drugs, which are the cyclooxygenase 1 and cyclooxygenase 2. The cyclooxygenase 1 enzyme is a housekeeping enzyme that is normally found majorly in the GI system. It's responsible for maintaining the GI lining, the normal GI mucosa production, bicarbonate production. So it's like it plays a protective role of protecting the stomach from the acid production. So when we give NSAIDs that target both COX-1 and COX-2, we normally diminish the activity of the cyclooxygenase 1 enzyme. So it's like we've stripped the protective role of that enzyme. So when we have hyperacidity or acid production, that protective barrier is removed. So we start digesting, or rather destroying, the gastric mucosa, leading to ulceration. So when I was saying that we need to switch the patient from NSAID COX-2 inhibitors, what I meant was the COX-2 NSAIDs will not inhibit the good protective roles of COX-1, so the patient will not experience that acidity.
Yeah.
So what are some of these NSAIDs that are non-selective for the COX-1, COX-2, and which are these COX-2 selective? So that when the patient is going to choose, maybe they have chronic pain that they need to manage. So which are some of these drugs that you would advise them to avoid so that they can't get the GI effects, the ulcerations, and the hyperacidity? Which are some of them?
Okay, the most common over-the-counter ones are diclofenac and ibuprofen.
Yeah.
Those are the two major ones that you'll find being dispensed. That should be avoided by the patient if they are experiencing hyperacidity. The selective ones that will not have that GI effect include the coxibs, the end in coxib, so something like celecoxib, etoricoxib, and all that. They'll help manage the pain as well as
without the GI effects.
Yeah, exactly.
So for someone who's managing maybe like arthritis, the etoricoxibs and the celecoxibs are a better.
Yeah, they are a better option because majorly you find those patients with arthritis, they normally use the NSAIDs chronically throughout their life. So suppose it was something like diclofenac being used, you see, it will have a lot of effects.
Also, on that note, there are instances where those people who are on arthritis, like there's no other painkiller that is really helping them. So in one way or another, you get that the physician recommends those that cause acidity. So I feel like one of the major ways that we can try and advise them is to take them strictly on after meals, so as to prevent that harshness of the NSAID. In a case where they cannot like completely do away with. Also with there's also some when you're compounding, there are some salts that are less harsh to the stomach. Like for example, incorporating diclofenac with the potassium salt in comparison with the sodium salt. So you find that the potassium one is less harsher to the GI.
And I've also seen some prescribers usually give PPIs, the proton pump inhibitors, prophylactically. So you might find that diclofenac is more effective in pain management, but due to its effect of hyperacidity, they normally prescribe along with something like omeprazole or rabeprazole.
That's, I think for a patient, when you are doing the therapy management, that for a patient who has, let's say, an old shosho, akona like 7 medications. So they have diclofenac and then they have a PPI because of the diclofenac. I think that's one we can do away with the diclofenac, so that we can also do away, because the pill burden will also be too much for the patient, for a person who has taking 7 medication. So it's also you can think about the patient and do away with the diclofenac, because that will also do away with the PPI, and then maybe introduce something less harsh, or maybe they can take the diclofenac when needed. They can be on the celecoxibs for a period of time, but for the diclofenac they can use it when needed. Also there are some formulations of the brufen that also tend to be less harsh on the GI, like the immediate release, or we can either have an immediate release, the soft gels. We've seen like one like the Gofen. Their major selling point.
Ibuprofen.
Yeah, that's ibuprofen. So their major selling point is that I believe it's immediate release. When it gets the stomach, it's absorbed quite very fast. It gives it less time to stay in the stomach, so it mitigates the GI effects. The side effects are lesser. So for a patient who's planning on going on ibuprofen for like a period of time, I would recommend going for those formulations that tend to provide fewer side effects.
Yeah.
So we were discussing the H. pylori.
So then you asked the question about the PPI. He explained the NSAIDs.
It's a proton pump inhibitor.
So for the PPIs, these are the proton pump inhibitors. So when you look at the physiology of acid production in the stomach, we go back to the parietal cell that is found in the interstitial. In the it's in the middle part of the stomach, which is called Antra.
I can't remember.
So there, the parietal cell is the one that produces the acid, right? So in the membrane, there's that proton pump that exchanges hydrogen ions with, is it potassium? Potassium ions. So the ideally how the proton pump inhibitors work, they inhibit that influx of the hydrogen ions to prevent it forming the hydrochloric acid, which is HCl. Now that is later secreted in the stomach, causing the acidity. So those are the drugs, examples like omeprazole, esomeprazole, rabeprazole, all of that. They function by inhibiting that hydrogen ion influx to prevent it from forming now the hydrochloric acid. So on that note, a question emerges. So when you use PPIs for long term, and we know that the stomach acid is ideally important in digestion, do you recommend using PPIs for long term, or what is your take on that?
I don't think you should use it long term. Once the gastric acidity has been put into control, I think you should stop using, because also remember that these PPIs have other side effects, like kidney toxicity, osteoporosis, and all that. So
imbalances.
Using them on a daily basis like that, I think it will lead to other problems.
So what is the maximum recommended period of time for use of a PPI?
I think it also boils down to finding the root cause of why we have the hyperacidity or the epigastric pain, because PPIs we are just basically managing the symptoms. So we can treat this patient the patient can be going for the PPIs because they relieve the symptoms, but they've not arrested the root cause, so they'll use these for months and months. But if we were to investigate the root cause, they won't be on PPI as long as they are not supposed to. And on which point do we introduce antacids to help now in neutralizing the acidity in the stomach? Is it when you're treating GERD, or?
I think majorly when you are treating GERD, we normally recommend the antacids first, because they help neutralize that reflux.
I think also for hyperacidity, it's you can attack it from different ways. So for the PPIs, we've said that they stop the acid production, and for the antacids, like the inositams, the calcium carbonates and the magnesium hydroxide, they are for neutralizing already produced acid. So for someone who's on GERD, if the major issue, if they are actively experiencing the reflux and the burning sensation, I think then they can use the inositams, the antacids, to neutralize that acid. But to prevent that from happening in the first place, we can use the PPIs. PPIs will sort of stop the acid production, but if the acid is produced, then they can use the inositams, the antacids on a need basis, the Gaviscons and such on a need basis. You can use both, just differently depending on how severe.
Also for GERD, there are good combinations whereby we combine a PPI with a prokinetic. A prokinetic is something that helps reduce
To-
the time the food
to
spends
increase
in
the
your
motility.
it increases the motility, and most of them you find they help close the lower esophageal sphincter. So you might find a combination like rabeprazole and itopride.
Itopride.
So that's actually a powerful combination for someone who has GERD. So combining that with an antacid will help manage that.
Yeah. So on the issue of H. pylori, there's the role of probiotic use in H. pylori, right? Or in stomach issues and stomach ulcers. How do you think probiotic helps in the stomach health?
When we started, we said that H. pylori is usually a commensal. It exists generally in the GIT. So in the cases that maybe the normal flora is, the good bacteria are very low, that's and maybe hyperacidity and the small erosion on the GI, that gives it an opportunity to grow. So by introducing probiotics, it's sort of boosting your normal flora, which in a way help fight against the bad bacteria from gaining power to overpower our GI.
Yeah. You take on that?
Yeah, I think my take is the same. So I think it's beneficial for the patient to be given probiotics as well, in order to help keep in check the balance between the H. pylori and the normal flora.
And also it will help mitigate some of the symptoms of H. pylori, like the diarrheas and such.
So we've spoken about the GERD, the stomach ulcers, but those are just some of the few issues that we experience. There are other issues like amoebas and diarrhea. So let's delve into diarrhea. So diarrhea is excessive emptying of your bowel, and it involves loss of a lot of water and electrolytes. So what do you think are some of the common causes of diarrhea?
The major cause of diarrhea, I would say, it's food poisoning. A lot of patients will come complaining of diarrhea right after eating maybe a street food. Yeah. So
Hygiene issues.
So if the food is prepared unhygienically, maybe people are not practicing good hygiene practices, like washing their hands and all that, they can introduce these microbes into the food. So when the patient takes that food, those bacteria rapidly multiply. So one of their most common effect is the irritation of the bowel. So you find patients with having a lot of diarrhea, pain in the gut.
Also for the kids, it also boils down to the hygiene issues, and because they tend to put their hands in their mouth quite a lot. Also the worms, the pinworms and the ascaris, they are very common in kids because of the frequent putting stuff in their mouth. So that's for the kids, pinworms and such are also a major cause of diarrhea.
Speaking of kids, when the kids are teething, usually that's rampant diarrhea. Do you think it's related to the hygiene issue or what?
I don't think so. I've never really understood why. And the diarrhea is also characteristic. The color is not the same as the
normal one.
I've never really known why they do that.
The same.
You check that out. So we have the diarrhea. We've already talked about some of the causes that are causing this diarrhea, and by the diarrhea is very serious.
It can be, yes.
It can be very serious, especially if it's something like cholera. You might end up dying within even 24 hours.
True. So because you're losing a lot of water, a lot of fluid, a lot of electrolytes, so we need to really have a checkup on that.
I think diarrhea can, in some cases, is an emergency for the kids. Because they tend to get dehydrated very, very, very fast. So I don't think we should treat diarrhea as it's one of the major causes of death in children under 5 years.
So in a setup, let's say you have a child, they're diarrheaing up to 3 times in a day. What are some of the first things that you will do to that baby in terms of management?
The first management will be rehydration.
Absolutely.
Exactly.
So you give the
Yes,
ORS, oral rehydration solutions. And also WHO recommends combining it with zinc.
Yeah.
Zinc is a good element that helps regenerate the gastric mucosa and also reduce those symptoms of diarrhea. So the oral rehydration solutions, their major play is to rehydrate the baby
Yeah.
and replenish those electrolytes that are lost.
Yeah.
Because if you don't control that, you might end up losing that child. So I think it's very important. And also, especially for babies, we don't jump to antibiotics.
Absolutely.
Most of the diarrhea we normally manage with the
Resolve,
ORS and
yeah.
the zinc.
Because most tend to be self-limiting. If it's food
Yeah.
poisoning, that should go away within 24 to 48 hours. Also, there's a staging of the diarrhea from moderate, mild, moderate to severe. So depending on that, our level of hydration also will differ. For the severe, you may need the kid to be on drip.
Yeah.
So I think you should also consult your doctor. Depending, you should take the kid to the hospital maybe to be seen if this kid is losing a lot of water, either diarrheaing or vomiting. Depending on how frequent they are vomiting or diarrheaing, the kid should be seen by the doctor. They may need more than just the ORS that we are given.
So in food poisoning, a person is excessively diarrheally. Do you think it's wise to give antidiarrheals to prevent the diarrhea, or do you think it's also wise to just let the diarrhea be and afterwards that the infection can just come out? What's your take on that?
I think one of the, for infective diarrhea, we do not recommend stopping the diarrhea because we know that these toxins need to come out.
Yeah.
So I would understand why someone would rush to get the Imodium to stop the diarrhea, but it's absolutely not the first thing that you should do. The toxins need to come out. And when you come to the pharmacy, without the proper history taking, you may fail to, you don't know if the diarrhea is infective or not.
Yeah.
So if the patient has a history of, I took something last night and later on my stomach is running, that is more often than not food poisoning. We don't need to stop that. So we can give the ORS, hydrate, and but if something like travel diarrhea or the motion sickness or such, that we can, because that's not effective. It's not effective diarrhea. For such cases, we can use the Imodiums. That's my take. The difference will be, is it effective in effective diarrhea or not?
Yeah. So diarrhea. So you say diarrhea has so many causes. One, teething, which is not the same. Then you have infections. Also we have amoebas. So when do you figure out? Okay, and then we also have something like bilharzia, where you have
and the
bloody
choleras.
and the choleras. So when do we know that now this diarrhea is not?
Okay, for cholera you will know because it's just explosive diarrhea, very frequent. You'll actually take yourself to the hospital very fast because it's uncontrollable and it's very painful. For the bloody diarrhea, they usually require more querying because there are some parasites that would give you a bloody diarrhea.
Yeah.
So there are a couple of them. So for that, maybe it's better managed in a clinical setup where they can do stool sampling and find really which microbe is causing that kind of diarrhea.
True.
So it will boil down basically to history taking. If I come to you and say, Doctor, I've had diarrhea for such and such a time with no history of taking anything prior, you won't query food poisoning. You'll know maybe it's something more than just simple food poisoning, and you'll recommend either empiric treatment with a broad spectrum antibiotic or antiprotozoal, or you will refer this patient to a clinical setup for further investigation. So the history taking is what will determine how to proceed.
So I think we have exhausted the diarrhea topic. So the next one that we'll delve into will be amoeba. And amoeba, one of the ways we tell our patient to prevent these amoebas is by constant deworming.
Yeah.
Amoeba, we deworm amoebas.
Yes. When you're deworming, so you tell the patient to take anti-amoebas,
The anti-amoebas,
the one that helps.
yeah.
And
True.
also the anti-helminths.
Yeah, because for people who especially use the tap water as their drinking water,
They are usually predisposed so
they're
much to
very
amoebas.
predisposed.
Yeah. So
for amoeba, you may also need a stool test, because this person will experience the symptoms for a period of time. They'll have a stomachache, they'll have a running stomach, maybe some vomiting. So for that, you can query something more than just food poisoning, and then they'll go in for a test, and then we can diagnose this is amoebiasis and treat it accordingly.
and some of the amoebas actually go unnoticed. Have you realized
Yeah.
that?
There are some people who are symptomatic. They just have amoeba, but
Because I had a patient who was telling me that they usually treat amoeba after every 3 months, and I was wondering, is that really amoeba?
Also, we are told that you shouldn't really treat asymptomatic amoeba if the patient is not really
Like she was
experiencing the
telling me,
symptoms.
like there's the way she feels and she knows it's amoeba.
maybe not, because
that's self-diagnosis.
absolutely
It could be
not.
even peptic ulcers,
Peptic ulcers
because some of the
or
symptoms
ascariasis.
There are no
coincide.
issues with heartburn.
Heartburn.
It's just diarrhea. And then like there's a way they're able to tell based on their stool consistency. She was telling me that when the stool goes to this consistency, then it changes the color. Then there's that stickiness and the smell.
And then
they
she
know
goes
this
for
is
the
amoeba.
anti-amoeba.
Yes.
And then also, but see the patients if you are to investigate further, maybe they also are an issue with either the food, the water they take. There are maybe hygiene issues like the mamambogas. You don't really confirm how clean the veggies are before you cook them. I think such cases, it can be even ascariasis. Ascariasis may present the same. You deworm and then it keeps on coming back. If that person has like a young child who's school going and all, they are more likely to bring these issues back home if the hygiene is not well considered. But I don't think anyone could say Nikona amoeba without
Without
you
further
can
diagnosis.
suspect amoeba, but we
Yeah.
don't know if for sure it's amoebiasis.
True. What else are you?
What are some of the management of the amoebiasis? We've diagnosed that this patient has amoeba.
Yeah.
We have drugs like metronidazole.
I think that's the go-to. Mtu nikona daktari naumwa na tumbo nipe Flagyl. That's the go-to.
But some people complain of its side effects.
Yeah, the taste.
And most patients will prefer secnidazole because it's just a single dose.
Yeah.
Instead of taking metronidazole for like 5 days.
Okay. I think we forgot to mention the management of the H. pylori. Now this patient has been diagnosed. They have H. pylori. What are some of the treatment options for this person?
So we usually go with either a triple therapy or a quadruple therapy, whereby the triple means we have 2 antibiotics, one targeting the aerobic bacteria and the other one anaerobic, and the other one we go for now an anti-amoeba. Like for example,
2 antibiotics and a PPI.
I mean the first one, and a PPI. And also we can top up with an antacid, which is not with or without an antacid.
Yeah, with or without, to manage the symptoms.
The symptoms of the heartburn.
So these therapies, you'll take the antibiotics for 2 weeks. And then you'll continue with the omeprazole or the ESO for an extra 2 to 4 weeks. Depending. So I think the patients really, the pill burden is quite a lot. Especially if you don't have the kit where they have 1 tablets and you are reconstituting these, unachukua uko na 250 amoxicillin, and then now the patient has to take two or times 2. It becomes quite a lot. I think proper patient education and counseling should be done to make the patient understand that if you don't complete this dosage, it's very likely that this will be a recurrent problem. We'll be treating it over and over again. And then the amoxicillin that was working before and the clarithrol, now it's not working. Now we have to move to a second second line treatment.
And H. pylori has really proven to be a notorious treatment. It fails in most of the cases. And I feel like we as prescribers should also tell the patient on the way we should take these drugs. Because you see, we have like 2 antibiotics and a PPI, and you know that the PPI is strictly before meals, at least 1 hour. So that information to the patient should also help in improving the compliance and the effectiveness of these antibiotics.
Absolutely.
And also adherence to medication. You need to strictly tell them you should
take them for
take
2 weeks.
The dosage.
Complete the dosage.
Don't skip the
because when we fail to tell the patients such kinds of information, you might find the patient taking the medication for 3-4 days. The symptoms have alleviated, so they assume that they are okay. But later on,
within a month or 2, they'll be back there treating the same issue, and now this time the first line won't work. Now we have to move to something more aggressive.
Also on the issue of the cost, I feel like one of the major things that causes that non-compliance is majorly on the cost, because these kits are very damn expensive. So we have to, you have to advise the patient to have to make sure, even though it's costly, like they really have to take this. Otherwise,
if maybe they can't afford the kit because they tend to be quite expensive, they can take like the drugs. We can constitute the drugs. We can take the amoxicillin.
But now the pill burden will be
too much. That will be too much for the patient. But if cost-wise they are not able to afford the kit, I think that will be the next way to go, with proper counseling, of course.
There are also complications that whereby you'll find a patient on PPIs, the acidity does not go away. So there are certain conditions whereby you might have constant hyperacidity, like the Zollinger-Ellison disease, whereby you have constant hyperacidity due to like a tumor that is constantly producing that acid. So it's important to refer such patients for further analysis to double down on the root cause, because you might find a patient coming to the hospital or chemist saying that they've been on 3-4 different kinds of H. pylori kits. Nothing is working. So I think further query is also important.
I think as it's a duty of us as professionals to know what cases are beyond us and refer these cases to a healthcare setting. Because when this patient keeps coming back to you, daktari, the dawa that you gave me last week is not working. Nimeenda kwingine nimepewa hii. We have to sit the patient down and explain to them why they need to go get seen for a proper diagnosis, or else we'll be treating this thing over and over and we'll just be managing symptoms at this point.
So we have actually listed some of the major common GI issues that we have. So on the other side, you as our listeners need to identify what is this symptom that you're feeling. So you know that this symptom is characteristic of this either peptic ulcer, is it GERD, is it amoeba, is it diarrhea. So you really need to provide proper history to the person who is where you're going to ask for assistance, so at least they can be able to diagnose it correctly and give you the right medication.
Absolutely.
So
be keen on, maybe you can check your stool, the consistency of the stool. Is there any blood spots? How long have you had these symptoms? Have you taken anything prior? I think these are some of the bits of the history that helps us as clinical healthcare workers to properly diagnose.
I think that's good.
Before we close, I would also urge the listeners, I think it's your right to ask your healthcare providers questions. Don't go uambiwe you have your H. pylori positive, tunakupea hizi dawa. Ask, what is the meaning of this? What does it mean that I have H. pylori? Why am I taking this amoxicillin? Ask these questions, so because we are here to help you. Usitoke kwa ofisi ya daktari ama kwa pharmacy without really understanding why you're taking medication. Because I encounter issues, what are incidences where a patient amefika kwa the counter and then anakuuliza na daktari mbona nakunywa hii dawa. That means that this patient has not understood their diagnosis. Maybe they felt a bit intimidated to ask questions to the person they were supposed to ask, or the patient goes and then comes back baadaye, and then when you inquire further, you realize this patient was not taking the medicine accurately. So I would really, really ask for patients to speak up. If they don't understand what the prescriber or the dispenser is saying, let them ask questions. It's absolutely their right to know.
True.
Yeah.
So guys, I think we'll be closing it at there. Thank you so much for listening. We hope to see you
In the next one.
See you in the next one.
Bye-bye.